do it. Hey, welcome back to the Clinical Leadership Podcast. I'm your host, Dr. Alex Earl. I'm joined today by Dr. Peter McCullough. Dr. McCullough, thank you so much for joining me today.
Thanks for having me.
Well, I've got a lot of questions and a lot of things to unpack after we've just had 3-4 years now of data to just unpack. So thank you again for coming on. I first heard you speak in person at Calvary Chapel, Chattanooga, back in October of 2021. We had just moved to Southeast Tennessee right before that. And man, you opened my eyes, and not just my eyes, but a lot of people. So for starters, I just want to thank you. Thank you for all the work that you're doing. There's a lot of people that are prayer warriors that are behind you, and I just can't thank you enough for all that you're doing for our country. I really am grateful, me and a lot of our listeners. So let's start with this. What do we need to know about coming from the chiropractic and physical therapy world? What can we do with our patients in this post-COVID era?
Well, let's just take your risks first. In the chiropractic physical therapy world, as you know, it's a hands-on specialty, right? It's hard to do it by Zoom. So many times you're working in close conditions, and I think whether it's SARS-CoV-2 or influenza or respiratory syncytial virus, you should realize that there are good strategies to reduce your risks and the patient's risks, and they don't involve masks. Unfortunately, masks don't stop transmission, but the nasal sprays and gargles do. So every chiropractor should know about nasal sprays and gargles. So the best data for prevention are with the xylitol-based nasal spray. So there's one commercial one called Clear, XLEAR, in a randomized trial by Baumforth and colleagues. There was over a 70% risk reduction in new COVID just by a couple squirts in each nostril twice a day. So XLEAR, there's another one called Neomed, xylitol-based. Xylitol is a natural sugar. It's derived from corn cobs. A lot of people don't know this, but what it does is it prevents adhesion of the virus. The virus can't get going and replicate as well. And then it tilts the microbiome towards the favorable bacteria that fight off the bad guys, the invaders. So there's probably always some virus in our nose and mouth all the time. And it's really a matter of, whether or not there's, a depression in our immune surveillance, and then suddenly we get a clinical infection, or we get an inoculant overwhelm. So both patients and chiropractors and physical therapists doing a prevention approach. Now, whether you do it every day or you do it on demand. I do it on demand in my clinic. Now, I do see patients face to face. I'm examining them, doing cardiac ultrasound. I do it on demand. What I mean by that, if somebody is clinically sick and they tell me they're sick, I'll do it afterwards, but I won't do it, every day. I guess I could. That'd be the first thing I'd want you to know. Has anybody in the chiropractic field gone over that with the group?
No, I've not heard anyone say that. I've only heard you. You mentioned that again back in Chattanooga. You mentioned it when I heard you live, and I have to give my wife some credit. She bought some of that X-Clear, and we had been using it every time I'd gone off and treated patients, or I'd gone off and gone to Costco. So I was familiar with it, and it was very validating to hear that that's what you recommended. For people that maybe don't know you or haven't followed your work, would you briefly describe the 4 pillars of the pandemic response? Because you just mentioned one of them, but I think this is really important. Should another event affect patient care for us, like you said, we're hands-on, we're face-to-face. What can we do to prevent measures and et cetera? But let's have you just talk briefly about those 4 pillars of pandemic response.
Right. But for those who don't know me, I'm a practicing internist and cardiologist, research epidemiologist, Dallas, Texas, and been a leader nationally in the pandemic response. I was the first to testify in the U.S. Senate on multi-drug treatment for COVID-19 at home in 2020, published the leading set of opinion editorials in The Hill. I was the first one publicly to question the vaccines, believe it or not. No one else did it in writing. Anybody you can talk to in the world. It's interesting that I'm the only one. Now, the 4 pillars I published in 2020, and it was the framework for U.S. Senate proceedings. It should have been, instead of Anthony Fauci, which is what we got, everyone saw the testimony recently from Fauci. instead of one person, we should have had teams of doctors, preferably qualified doctors who are seeing and examining patients. The first pillar would be contagion control, and to reduce the spread of the illness. What worked there with the nasal sprays and gargles, so xylitol-based sprays and gargles, and the gargle, by the way, is called Spry. Those are preventive. For acute treatment, we change over to iodine-based sprays and gargles. Iodine-based would be Cofix RX, betadine, or a homemade iodine, a couple drops in saline solution for a nasal spray, a couple drops in scope or Listerine for the gargle. Iodine for acute treatment, you can do that up to every 4 hours. Those two things would have reduced the immediate spread of the virus. If you're sick at home and you don't want your spouse or your kids to get the illness, that's the first thing you do is nasal sprays and gargles. People are always worried about hand sanitizer. Most of these viruses are not contact viruses, not Ebola. They're actually spread in an aerosol in the air. And how you cut down on giving and receiving is to kill some of the viruses with iodine. Now, you don't kill all of them, but the theory is you kill enough where your body's own immune system can knock it down. You don't get a full-blown head cold with congestion. Pillar number 2 is early multi-drug treatment. So there, for most viral infections, you and I wouldn't need it because we're young enough and we're healthy enough. All the published studies suggest only 25% of the adult population is really at risk for anything. Now, they include the elderly. In the elderly, certainly above 85, many would consider over 75. Obesity, diabetes, those who have trouble breathing at baseline for any condition, sleep apnea, emphysema, asthma, heart failure, people who are just particularly frail. Those are the high-risk people. The type of people who you think could not survive a hip fracture, or couldn't survive a motor vehicle accident, or couldn't survive a community-acquired bacterial pneumonia, those would be the people we'd worry about the most with any infection. So those would be the people who would risk stratify for early treatment. With SARS-CoV-2, we relied on nutraceuticals and supplements over the counter. Then we got into antivirals, corticosteroids and anti-inflammatories and antithrombotics. But the over-the-counter products that any chiropractor could recommend probably hold true for other viral infections, just like the days. So we should spend time in them. So they include aspirin. Aspirin as a low dose is reasonable in viral infections, not because they really treat the viral infection, is that because almost all viral infections in certainly men over 45, women over 65, they can trigger a heart attack. Influenza can do this, COVID can do this. And it's about a 6-week window. So as a cardiologist, I always want my patients to be taking some aspirin because I don't want to, I want to try to prevent that triggering of a heart attack. The next one is vitamin C. Vitamin C is an antioxidant. And what we've learned on this, it has to be vitamin C in pretty good doses, like 3,000 milligrams or 3 grams 4 times a day, a lot more than what we used to. There are some studies taking it up to 50,000 grams a day, but it's certainly higher than what you normally do. Vitamin D is almost certainly therapeutic, but at higher doses, 20,000 units a day. Some actually go to 50,000 units a day. In short term, this is safe and reasonable. A polyphenol supplement, quercetin, appears to have a role, 500 milligrams a day. And then we use an over-the-counter kind of antiviral, anti-inflammatory, antihistamine, which is famotidine. It's actually a stomach medicine, but we use it in high doses, 80 milligrams a day, and that's supported by actually a very large study from University of Virginia. That's what's called the over-the-counter bundle in McCullough protocol. So, that would be the next step. People say, well, I got another cold coming in. I don't know what it is. Get on these principles. If you go to petermcculloughmd.com, go to McCullough protocol. It's copyrighted, but there's no intellectual property or money associated with it. It's just copyrighted so people can locate it. They know a name to attach to what we're talking about. McCullough protocol is the most widely used method to treat COVID-19 in the world in history. It has been, attributed to saving tens of millions of lives, sparing hundreds of millions of hospitalization, far more impactful than any vaccine.
Excellent. So that leads us to pillar 3. right? Pillar three of your pandemic response. So let's talk about that because the hospitalization is a touchy issue.
Mm.
And I think you and I would agree that the propensity to just watch the symptoms and not treat, I've certainly heard you talk about that, how no other condition, like no other, ailment where we just waited and, saw what was happening to someone. That was always odd to me. And so just talk a little bit more about the hospitalization phenomenon of your pillar three.
Well, when patients do require hospitalization, we want them to get the highest quality care. And the goal is to spend as little time in the hospital and get out alive. That's really the
Right?
goal of
Yeah.
hospitalization. A few observations with COVID. Early on, there were some publications from the paramedic units picking up patients who were sick with COVID. And you know what they found is that when they picked up patients who said, listen, I can't take it anymore, take me to the hospital, the vast majority were not put on the mechanical ventilator. The paramedics actually found them to be breathing okay. A large number of the hospitalizations, maybe even 75% or so, were out of panic. People just panicked.
Hmm.
So the first lesson is don't panic. The reasons to go to the hospital is when you really can't breathe anymore. The work of breathing, typically more than 35 breaths a minute, can't be sustained. People not thinking correctly,
Sure.
they're so sufficiently winded. We've learned not to rely on the oxygen saturation. A lot of people had pulse oximeters at home. Normal is greater than 95%, but we learned over time it was common to have people in the 80s. We treated this easily at home. I even treated patients, now I'm a specialist, but I treated patients with O2 saturations in the 70s at home for weeks. It's called
Wow.
permissive hypoxemia. We've published on it. It's safe to do. And as long as we don't exceed those parameters, we know that if any patient went to the hospital with oxygen saturations in the 70s, they'd be put on a ventilator. And if they got put on a ventilator, the chances they would get now a ventilator-associated bacterial pneumonia were sky high. People actually died of ventilator-associated pneumonias and also barotrauma. That is a mechanical ventilator blowing out the lungs and collapsing lungs. I had this happen in one of my patients. And so the mechanical ventilator didn't save patients. And the reasons for hospitalization were for respiratory support or just dehydration, need an IV. There were some later advanced treatments that could be done in the hospital. But what we learned is the featured drugs, remdesivir, baricitinib, these weren't associated with reductions in mortality. The steroids used, dexamethasone was a low and odd dose. We used prednisone at home as a common steroid. It worked better. So the hospitalization for COVID-19 didn't have a spectacular track record. The in-hospital mortality in some studies was 90% if they went on a ventilator. Even a recent Johns Hopkins study, years into the pandemic, showed hospitalizations 30% mortality. That's sky high. The most dangerous heart attack I face as a cardiologist, there's a 2% mortality. So COVID inpatient mortality unacceptably sky high. The mistakes made in the hospital was they failed to honor medication reconciliation. So if a patient was on McCullough protocol at home, that should have been continued through. And when that was, the patients would survive and go home. But when they shut off the outpatient medicines, they stripped away everything away from them. That violated their rights and actually was a step down in care. The second issue in the hospital is the failure to honor shared decision making. So as patients learned, and they said, listen, the ICON study showed that in hospital, ivermectin reduced mortality by 50%. Patients say, listen, I want ivermectin. That's safer than Tylenol. And yet they were denied even a simple, safe, available medicine. It was really just in the formulary down the hall, and patients were denied care. The other part of the hospitalization, which was tragic, is the denial of the right to see loved ones. So in almost all the cases, the patient was at home being taken care of by their family. So they had tons of exposure to one another. And so suddenly the patient goes in the hospital and they can no longer see them. So listen, I was with grandmother for 2 weeks. As either I had it or I didn't have it, or I'm willing to take these risks. Let me go into the hospital and see my grandmother. And people were not allowed to do that. So this was a great tragedy. Lessons learned. People need to understand their rights. when they go in the hospital, take all your medicines with you. Do not give them up. You have the right to continue to take your medicines. Family members have the rights to see their patients, and they have to demand it if they have to, get an ombudsman or a patient advocate or even a lawyer for that reason. Being stripped of rights and then dying in the hospital, and virtually all the deaths occur in the hospital, were two of the great, really criminal tragedies of the pandemic.
Yeah, we're going to come back to that in a little bit because I think the patients, right, there's a patient's bill of rights, right, that I think a lot of people threw out the door when people would enter into patient care just under the umbrella or the banner of COVID treatment. And so we're going to come back to that in a minute here, but I want to just wrap up your four pillars that we were talking about for the pandemic response, because vaccines, especially my profession, gets labeled anti-vax for simply questioning. It's just kind of we're in the alternative health sphere. And there's a lot of chiropractors that have been vaccinated. There's a lot of chiropractors that are just against it. So we have a healthy mixture of opinions on the topic. But what I care about is the data. I care about the facts, and I care about opinions second, but give me the facts first, right? And that's kind of what the way that I look at it. And then if you give me all the information, I feel like I'm in tune enough with my body, or in tune enough with decisions that I can make a good decision if I have all of the information. But if I don't have all the information, I have to really, I don't know, I have to take someone's word for it. And I don't know about you, but I needed a little bit more than just, hey, we need to take it, or otherwise here's some lotto tickets, what type of coercion techniques that they had for me to take it. But it was like, I need to know more information. So talk to me about the role the vaccines play in pandemic response.
Well, first off, let's just talk about numbers. There's about 1 million MDs and DOs, about 90% MDs, 10% DOs, and there's 500,000 nurse practitioners and PAs. My count is, I think there's probably 70,000 chiropractors, something like
Yeah, I
that.
think, between 70, 75,000. Yeah, you're right.
Yeah. So it's a numbers situation now. And then we got, I don't know, millions of nurses. Almost anybody in a hospital setting is effectively forced into vaccination. Our childhood vaccine cards are reviewed. We're told we have to take more shots. When I went to medical school, I was told my MMR was out of date, so I needed more MMR shots as an adult, annual flu shots. So almost all of us, because of this effective forced vaccination, we've taken many vaccines. I had 69 shots in my life. So there's no way I'm, anti-vax or, against the narrative. I took all the shots. I've been compliant. But just because I took all the vaccines and I didn't have a side effect doesn't mean it right for someone else to take one and have a problem. Now, when we apply this crucible of the pandemic, many have said, listen, don't vaccinate at all into a highly prevalent pandemic, more than 5, 10, 15% of people having the illness at any one time. Because if we do that, there's enough vaccinated people, but there's enough virus around, the virus will figure it out and become resistant to the vaccines. That was the first principle. It's like, ooh, this doesn't look good, because the vaccines can't be changed quick enough. The virus always outsmarts the vaccines, and we're going to get resistant strains. And that's what we exactly got. Now, during the pandemic, I was very active in research. So I was the assistant to a major research program with the Imodulon vaccine. So I was a co-principal investigator of a vaccine program. Now, Imodulon was a cellular-based vaccine similar to the BCG. It was just going to kind of boost the immune system. And when we sketched this out for the FDA and Operation Warp Speed, I did this part of the grant. It was only going to be for about 2.7 million people in the United States. So I thought maybe 2.7 million at the most should ever get, a safe, potentially helpful vaccine. And that would have been people who still haven't had COVID. So they were naive to COVID, and they were in nursing homes or congregate settings, and maybe the people taking care of those individuals. That's it. That's it. We should never introduce a vaccine generally into the community in the setting of a pandemic. And boy, what a disaster it was with the COVID-19 vaccines that were ushered in. They were brand new genetic technology. There's no way to shut off the genetic production of the damaging and lethal spike protein. I was the only person in the world who wrote an op-ed on this, published in the Hill, saying, wait a minute, this is a gamble. How do we shut this off? Has anybody thought this through? Where's the vaccine going to go in the body? What if the spike protein gets into the heart, the brain, the organs? Turned out, yes, 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 all of that is true. The COVID-19 vaccines have been a debacle from the very beginning because they have a dangerous mechanism of action. And none of the manufacturers, the FDA, none of the government agencies for a second questioned the safety of the vaccines from the very beginning. And to this day, they don't.
Yeah, it was interesting how you start to see some of these adverse reactions to the spike protein, right? We're going to talk about that next. But you would see all over the media, people would say, well, there's no evidence that the vaccine is causing this. They just kept saying it over and there's no evidence, there's no evidence. It's like, but I'm observing it, right? I understand facts are different than evidence, but I'm seeing a correlation here. So it doesn't take a, genius to figure out, what the patterns that I'm observing here. So I'm allowed to question it. I think so. But I guess you can't observe and then question, right? Like that puts you in a territory that very few are willing to go.
Well, wait a minute. Let's talk about this idea of observing. Like, what can you do as a chiropractor and observe? It's reasonable to apply the Hill's tenets of causality, just to think through this. So the first tenet of causality is, do the vaccines have a dangerous mechanism of action? Yes, they're the genetic code for the lethal part of the virus. And the genetic code that's synthetic, and we can't turn it off. So it's going to produce endless amounts of spike protein. In some people, could it produce enough to kill them? For sure. So a dangerous mechanism of action, that's one of the first criteria. The second one is temporal association. Did a patient report something to you? They took the shot, and then right away they had the side effect. I mean, they were fine until they took the shot. So temporal association is pretty strong. In the US CDC database now, we have 18,655 vaccine deaths where doctors like me have reported the death. We've determined the vaccine is the cause of death. Otherwise, we don't report it. It's called the VAERS system. 18,655. Now, of those deaths, 1,150 occur right in the vaccine center or a few minutes driving home. They die right there. And the paramedics are called. And so, I mean, it's immediate. Now, another 1,200 die the next day. So, someone healthy enough to walk into a vaccine center and they die in the vaccine center, it is just, it's beyond my imagination that anyone would say, well, that's not due to the vaccine. I mean, that large number of deaths on the same day they take the shot, that should have triggered an immediate halt to the vaccine in January of 2021. People said, why are people dying in the vaccine center? The only thing we heard was that people were dying in the vaccine center and we needed to have CPR and resuscitation equipment. That was actually the response. So one of the most censored guy on social media is Harry Fisher. You may see him. He's a paramedic. And he wrote an essay that was published on my Substack. He said that when they were being called out to these vaccine centers, people were dying right in the center, and he'd be doing CPR and shocking the patients. He would look over his shoulder and look back in the line, and no one got out of line. They literally watched the person right in front of them die with the shot, and then they lined up and got a shot.
Wow.
So yeah, I mean, wow, it just shows you what a mass trance or mass formation people were in. Now, the other tenets of causality is, is it internally consistent within all these same databases? Do we see near misses like heart attacks and blood clots and all these other non-fatal things? For sure. Is it externally consistent? Is what we're seeing in the United States in the US VAERS system, is it the same as the yellow card system in the UK? Yes. The EU UDRA system? Yes. The WHO VigiSafe system? Yes. All the databases agree. Is there coherence? If we look at the peer-reviewed literature, there's 4,000 peer-reviewed papers describing fatal and non-fatal injuries. It is compelling that these tenets of causality have been fulfilled, and they're fulfilled via our observation of patients and our observation of the medical literature. So I think you're well supported in your concerns that the vaccines are causing people to lose their lives.
Yeah. So The next thing I want to talk about is, as we mentioned early on, like we're very hands-on, we see our patients, so that
Mhm.
exposure risk is there. Like we almost accept that, right? And then what about the patients that have either been vaccinated or have experienced long COVID? And especially in offices like ours, where we do manual therapy, we do rehabilitation exercises, stretching, we do forms of treatment like that where people are up and moving, and they might be a little fearful of starting to move again. Right. So what advice
Mhm.
would you have for people getting back into we know that the exercise is going to
Mhm.
be beneficial with them on a graded exposure, but maybe how would you communicate with them that this is a good thing for them
Mhm.
in our offices to continue on?
Well, exercise and fitness are pivotal, but it's important for the chiropractors to realize that many of the long COVID patients and the vaccine patients, they have a problem of what we call autonomic dysfunction, or a clinical syndrome called POTS, postural orthostatic tachycardia syndrome. They have excessive heart rates and variability in blood pressure with exercise due to the spike protein. It's well understood. So certainly taking a blood pressure in the office, very reasonable, reassuring to patients. And then having them start out gradual. I like a mix of aerobic and strength activities. I'm greatly worried about our seniors, getting so sufficiently debilitated they fall and break a hip or have a cervical fracture or radial fracture. And then people need to work into it. For every day being in bed, you lose about like a week or a month of fitness. There's some calculus there in terms of the
Yeah.
peak oxygen consumption,
Yeah, for
right?
every like 24 hours of disuse, muscle atrophy kicks in, and it could take you could lose
Yeah,
30% of muscle strength within 3 weeks, and it takes 12 weeks to regain a percentage of that back. So yeah,
that's
yeah,
it.
to your point, it takes the disuse atrophy. Is it, a lack of strength? Is it a lack of coordination? Is it a lack of balance? All of the above. That's what leads to the fall. Same thing happened to my grandfather. He fell, broke a hip, and his health declined significantly.
Yep.
Thankfully, this was, before COVID, so it wasn't. But the lack of strength and coordination and balance, that really was a detriment to his health, and his health was never the same after the fractured hip.
Mm.
So I completely agree with you. Go on. This is very helpful.
Yeah. Well, one of my patients in Dallas, when she got acute COVID in 2021, actually 2020 is when she got it. The manifestation was she fell in her backyard and she suffered a fracture because she was so dizzy and weak with COVID. So now she has the fracture, and but she got McCullough protocol. She had just gotten back from MD Anderson Cancer Research Center, treated for breast cancer, got COVID. It was a severe form. She's debilitated, falls and has a fracture. But, fortunately, I was able to treat her McCullough protocol and got her through. But the point is, on fitness is a great risk to everybody is another episode of COVID or another episode of influenza. And the principles there are fitness. Fitness is what carries us through in terms of cardiopulmonary fitness. We can measure that in terms of peak oxygen consumption or metabolic equivalence of work. One needs to get out there and sweat, exercise to the point of breathlessness, and then rest, and then push again. Need a combination of strength exercises that you guys are excellent in coaching people on. Balance, that's something different than fitness and strength. Balance. And then lastly, flexibility. These are all very, very important. I intentionally, people ask me, well, why do you exercise so much? It's not because exercise itself prolongs life, but it actually prepares one to be able to handle a crisis, a motor vehicle accident, a severe infection, a cancer, or in this case, an infectious disease.
Yeah, I mean that's my bias right there. Movement. You're right. It's not that it prevents things, but it does. It in essence reduces your risk of all-cause mortality, just because you can't go wrong with getting strong, as a therapist I know has said frequently. So a couple things I want to touch on real quick if we have time. The first is the spike protein, one of the most commonly asked questions, and I did put out a feeler on a lot of people in our network. What would you guys like to know from Dr. McCullough? And a lot of questions came back regarding the spike protein. How long does it remain in the body? Can it ever leave? Tell me a little bit more about the spike protein, because people are really curious about it.
The spike protein is the spine on the surface of the virus. It's about 1,200 amino acids in size, about 3,400 base pairs code for it, some glycosylation side chains. It's been manipulated in the Chinese Wuhan Institute of Virology. That really was the subject of gain of function research. The spike protein damages blood vessel cells and endothelial cells. It sticks to red blood cells. It causes blood clots. It's found in the heart, causing damage, found in the brain. It's a bad actor. It's a bad actor.
That paper just came out showing myocarditis in the vaccination group that was not present in the
Right.
unvaccinated group.
Well,
Yep.
here's the thing. As the spike protein in the SARS-CoV-2 infection, as the spike protein encounters the ACE2 receptor, the S2 segment is sacrificed and S1 gets in. So S1 is limited. With the vaccine, you get the genetic code installed in the body and the full length spike is produced for an endless period of time. And then shots every 6 months are like boosters. They just keep producing more and more spike protein. So Brogna and colleagues from Germany have shown that the spike protein is fully intact in the vaccinated and circulating in blood for 6 months or longer. The spike protein trimerizes. It actually travels in threes like a twisty tie. And the spike protein has a great longevity in the human body. We don't know how long beyond 6 months, but it's at least that. And there are no human enzymes that are known to break down the spike protein. So this is very, very frightening. And there's other infections that are similar. So for instance, Lyme disease, Borrelia burgdorferi, the body has trouble breaking down the Lyme organism. Syphilis gets in the body. It's very, very hard to break it down. So this is not uncommon, but it is a problem. So people have asked in the chiropractic setting, is there shedding? Can someone actually take a vaccine or have COVID and the spike protein be shedded? The spike protein has been shown to be in exosomes in a paper by Banzel and colleagues. So it probably is in exhaled breath as an example, or in sweat or body fluids. That's possible. But when you encounter the spike protein without it being the virus, chances are you're just getting an immune challenge in the mucosa or on your hands. And that's it. I had that happen to me once, and I talked to an expert on this, and I felt just a little, like a little funny for a few hours. He goes, "Yeah, you're just getting an immune re-challenge." So to be re-challenged with the spike proteins, not a bad thing. The immune re-challenge, though, can be enough, and there's enough studies on this. It's called shedding, particularly where the recipient is an unvaccinated woman. Where they come in contact with someone else, it can actually change the periods. There's been enough studies on that's shown this, and women have reported this over and over again. They did manipulation on a vaccinated patient, and they didn't have a period for 3 months. So that's probably real. Now, other getting seriously ill that has not been described, getting messenger RNA into another body via touching, kissing, sexual intercourse, blood transfusion. It's never been described. Messenger RNA getting into the body through breastfeeding and through cord blood into the baby. That's been shown. But still, there's a lot we don't know.
Well, what I've seen, and thanks for bringing up even women's health and their cycle, because what we've seen is in our intake paperwork and in our intake process, we do ask, especially if someone comes in with back pain, we still ask about any changes in bowel or bladder. And in women, we ask about changes in their cycle. And it's a data point how many women have had significant changes in their cycle. It's surprising. Well, maybe not anymore altogether. That's surprising, but it's an interesting data point. So last question about kind of the chronic pain aspect, because we do get a lot of people with chronic mechanical pain that come into our office. And again, this might be anecdotal. This might be something that I've observed, but talk a little bit about maybe the adverse response to vaccination in the chronic pain population, if you can.
Anybody with chronic illness, let's say fibromyalgia, as a classic example, they're going to get way worse after the vaccine. Anybody with any neuromuscular problem, Guillain-Barré syndrome, for instance, is going to get way worse, myasthenia gravis. There's a couple
Lupus,
of pain syndromes that are worth noting. One is any of these craniofacial cervical pain syndromes. There are data to support what's called stellate ganglion block. And that's a technique using ultrasound. It's typically done by a pain specialist, anesthesiologist. They use ultrasound. identify the stellate ganglion, and just inject some lidocaine in there. And what happens is it's a feedback loop between the brain and the cranial nerves and the stellate ganglion, the sympathetic nervous system. It's a feedback loop, and the lidocaine just shuts off that for a while, and then it resets. And some people, it's a few injections, and they're basically fine, just sometimes one. So any of these cranial facial things, loss of taste and smell, ringing in the ears, pain in distribution, trigeminal or facial pain, consider a trigeminal neuralgia, consider a stellate ganglion block.
Excellent.
Look for, in these syndromes, look for any lesions in the ear, and then changes in the pupils or the eyelids or the facial symmetry. That's called Ramsay-Hunt syndrome. Ramsay-Hunt syndrome is a classic vaccine injury syndrome. Justin Bieber has that. Justin Bieber has Ramsay-Hunt syndrome. He hasn't been able to be in a concert for years now. So you want to identify that. If I identify Ramsay-Hunt syndrome, I treat it very aggressively with valacyclovir and prednisone. It's a varicella-zoster virus syndrome. Just like with Bell's palsy, you want to identify that. For the rest of the myalgia, arthralgia, panel of syndromes, what I do is I try to make a diagnosis, and I measure blood tests for autoimmunity, the ANA, the anti-citrulated peptide rheumatoid factor, and if there's any cutaneous or renal manifestations, I order an ANCA, antinuclear cytoplasmic antibody, and I make a diagnosis. Sometimes, therapy is warranted, but the majority who are negative, and they simply have a myalgia syndrome or arthralgia syndrome, low back pain, I think they're great candidates for the hands-on treatments and everything you do in chiropractic practice.
Yeah, thanks for that, because that's ultimately the goal, right? Is we can have this integrated model of pharmaceuticals and nutraceuticals and physical fitness, ultimately because I think our patients deserve better. I really do, and I think that they deserve our best. And so, I want to go back to one other thing, because I did just mention nutraceuticals. So having learned a little bit more and having followed you for a bit, what specific nutraceuticals or supplements? I know you mentioned earlier, aspirin a little bit, and then you also mentioned vitamin C, vitamin D. What else could we either have on our shelves? What resources could we recommend to patients that we're dealing with from a mechanical standpoint, but also from like an overall immune boosting or preventative measure?
Well, when we're on the back end, most people have been through COVID now or taken vaccines. We're greatly interested in what's called spike protein detoxification. Can we get the spike protein out of the body? 2 peer-reviewed papers as a proposal. The combined use of nattokinase, a derivative of the fermentation of soy, bromelain derived from the stems of pineapples, and curcumin derived from turmeric, in combination in between meals is considered McCullough protocol-based spike protein detoxification. Again, it's centered on my name just so people know what it is. There's no patents or anything filed on this. And so many companies have put together, wonderful trios of these products. So nattokinase, 2,000 units twice a day, and that dose can range upwards. Bromelain, 500 milligrams once a day, again, can go up, and curcumin, 500 milligrams twice a day. Now, curcumin, we usually add in piperine, which is black pepper extract, to get it to be absorbed. And these are starting doses that we, can double or triple or more. The main caveat is bleeding. 2 of them tend to be anticoagulant. But what we have observed is that people slowly improve over time. It's the only hope we can get rid of the spike protein. The spike protein is causing inflammation. A lot of centers ignore the spike protein and just deal with the inflammation. What I've found is if you don't do something about the spike protein, they ultimately will get sick again. You can't avoid it. So if you go to Mayo Clinic, for instance, they just ignore the spike protein and try to treat inflammation. It doesn't work. We actually have to treat the fundamental problem. Chiropractors can learn McCullough protocol-based spike detoxification at petermcculloughmd.com. It's a great thing to recommend in your office. It'd be a great office product trio to offer. There's many available. Amazon, or I advise a wellness company on a trio. It's perfectly fine. And get going on detoxification for sure. I mean, that should be in the nutraceutical cabinet. I think everybody, almost everybody in the world ought to be on that now. And some people say, well, how long? I said, I've learned now at least a year. Japanese take nattokinase indefinitely because it has heart protective properties. I'm probably going to do that myself. Take it into. I don't seem to have any side effects, and the data are overwhelmingly positive. Other things that can be added to it: N-acetylcysteine, fine. Clearly, vitamin C is an antioxidant, fine. There are some non-medicinal strategies that really make a lot of sense. Sauna therapy and sweating. Try to kind of sweat out some of the spike protein. Terrific. Hyperbaric oxygen treatment. Hyperbaric. Every study done in hyperbaric in long COVID or vaccine injury syndrome, positive.
Excellent. Excellent. And we'll have links in the show notes for all of those, the wellness company we're big fans of. So we will definitely include links at the bottom. That was a little bit of looking back and kind of what we can do with COVID. What about looking forward? What are some things that we need to keep our eyes open to in the future here?
And be aware that all of the interest groups in pandemic response have signaled that there's going to be another pandemic, from Anthony Fauci to the World Economic Forum to the World Health Organization, the CDC, all the government agencies. They call it Disease X. And it looks like Disease X is here in the form of bird flu. We're talking highly pathogenic avian influenza H5N1 bird flu. And a breaking paper out today, McCullough Foundation has really broken the news. We think the proximal origin of the bird flu outbreak is actually another lab, the Southeastern Poultry Research Lab in Athens, Georgia. We nearly got this nailed down. Looks like it's not very dangerous to humans. 3 cases so far with clinical description of just some pink eye. One guy had a dry cough, no fever. In animals so far, mild. It's being transported by mallard ducks. We're not seeing a die-off of the mallard ducks. The chickens, right now, there's not large numbers of chickens dying. It's just that when they do PCR testing and they're test positive, the reflex is to destroy all the chickens in the flock. And I think the farmers are going to have to resist this. Let the chickens get through this with natural immunity, just like the mallard ducks are doing, to have this terminate. We do not need to start vaccinating the poultry. That doesn't work. The Chinese have tried that for decades. It just causes more spread. And it's not time for human vaccines. We saw 2 FDA officials on Capitol Hill in the last 2 weeks, getting lathered up for mass vaccination. In fact, the US government's actually bought bird flu vaccines for humans. Now, they can't be tested on humans because no humans have had it to be tested in a clinical trial. And I'd caution anybody about human bird flu vaccine. It looks very mild. Wellness company, we got contagion kits that can, cover this with ultrasemivir and even hydroxychloroquine has some effect. You can, again, use a dilute iodine nasal drop and gargle to kill the bird flu virus. So we haven't had a death due to bird flu in the United States, and we're not going to.
Well, I'm glad you brought up animals, though. Like, how much of a risk do we need to, or how much fear or how much worry do we need to have about contagion getting into the food supply?
Yeah, and people have already tested raw milk and tested, chicken meat. I think it's greatly overblown. What we need some careful observation. Let the birds get through it. Listen, bird flu existed hundreds of years ago. Right. We didn't have mass panic in our farming and food techniques 100 years ago. We shouldn't have it now.
Excellent. Excellent. Dr. Peter McCullough, thank you for joining me today. I really appreciate you coming on.
Thank you. Make sure you follow me at petermcculloughmd.com. That's the central website. Then my book, couragetofacecovid.com. My Substack, Courageous Discourse, the best medical Substack out there. And then McCullough Report, America Out Loud Talk Radio. McCullough Report. It's on the podcast circuit. I interview people really from all over the world. And it's been a great honor. I was on national TV last night, prime time, with one of our U.S. House of Representatives. And I'm doing everything I can, like you are, to bring people the truth, give them a dispassionate, kind of concrete set of action items to guide them through this series of infectious disease threats, many of which are man-made and are greatly amplified by this biopharmaceutical complex that has formed, this kind of working syndicate of public health officials and vaccine developers.
Well, again, thank you so much. We'll make sure we include all of those in the show notes, and we're going to encourage all of our audience to follow you, to subscribe to your Substack, to just keep track of all the good work that you're doing in the world. It was a pleasure and an honor to have you on today. I know you're busy. I know you're very busy doing a lot of many things, but we're praying for you, and we are in your corner. All right, sir.
Thank you. Thank you. God bless
Uh,
you.